Шановні колеги, шановні друзі, ми раді вас вітати на
Dear
другому
colleagues,
дні
dear friends, we are happy to welcome you all at our second day of our 14th seminar on track to improve health of women living with HIV Ukraine, organized by the working group on European AIDS Clinical Society EX, which is WAVE, Women Against Viruses in Europe. And they're focusing attention on women living with HIV. And as you might remember, yesterday we talked about mental health and adherence to treatment in women living with HIV. And today we are going to discuss a really important topic as well, metabolic disorders in women living with HIV. And just to remind you, you'll be able to get your certificates after our stream is over, when you will start to get access to the survey. You will have to undergo this survey, and it's not just to assess the level of your knowledge, it's just your impressions of this webinar. And what do you think of the information that will be shared today? So in the beginning, I would like to introduce our co-chairs for today. And first is Dr. Nina Weiss, who is a professor, PhD, medical doctor, Copenhagen University Hospital, Vidovre, Department of Infectious Diseases, University of Copenhagen, Faculty of Health and Medical Sciences, Department of Clinical Medicine, Denmark. And she is the head of WAVE today. And Nina, we are very grateful to you that you are with us. We'll be happy if you will say just a few words to our participants.
Thank you very much for this very kind introduction. As Sergej mentioned, I'm an infectious disease specialist at University Hospital Copenhagen Hvidovre in Copenhagen, Denmark, and professor at University of Copenhagen. But I think the most important role today is that I'm chair of Women Against Viruses in Europe, WAVE, a working group under the European AIDS Clinical Society. I have participated in these meetings several times through all the years, and I'm so impressed with what Sergej and all Sergej's collaborators arrange twice a year with these workshops. I'm very sorry that I couldn't participate yesterday. I have heard that there was a very lively discussion and a lot of participants. But I'm very happy that I can participate today, and I have been looking very much forward to hear about cardiometabolic disorders and metabolic syndrome in women living with HIV. It is a difficult time we live in. We thought that we had kind of control over the HIV pandemic, but as the global climate changes, and by this also the support to really take care of patients with HIV, I think it is extremely important we know exactly how to treat our patients in the clinic the best way we can. And I have been looking very much forward to learn about these two things today, both with the mini lectures and with the case presentations. So thank you for hosting us, and I'm looking very much forward. Thank you.
Дякую, дуже дякую, пані Ніно, за теплі
Thank you
слова.
so much, Ms. Nina, for these warm words. Every time you join our seminars, we are really happy that you are able to participate. And now I would like to introduce our second co-chair, Svetlana Antonyak, infectious diseases specialist, Gromashevsky Institute of Technology, Infectious Diseases, HIV/AIDS, and Viral Hepatitis Department, Kyiv, Ukraine, and honored doctor of Ukraine. Ms. Svetlana, you're welcome. Dear colleagues, I'm really very pleased to welcome you to the 14th WAVE EX webinar on track to improve health of women living with HIV Ukraine. And sincerely thank you for your interest and for taking the time to participate in this webinar and discuss important issues regarding modern approaches to early diagnosis and proper management of metabolic disorders. And that is the topic of our session today. And with a special focus on the needs of women living with HIV who are receiving antiretroviral therapy. I would like to extend my warmest thanks, as is our tradition, to Dr. Caroline Abbey Pope, Master of Sciences, who works as a consultant, obstetrician, gynecologist, and researcher at the Department of Infectious Diseases at the University Hospital of Bern, Switzerland, and who in 2019, together with Professor Justyna Kowalska of the Medical University of Warsaw and Professor Fiona Mulcahy, who worked at St. James Hospital in Dublin, at that time inspired us to organize the WAVE EX webinars on track to improve the health of women living with HIV Ukraine. And I would like to express my gratitude to Professor Nina Weiss, medical doctor from Copenhagen University Hospital Vidovre and professor of the Department of Infectious Diseases at the University of Copenhagen, Denmark, who currently serves as chair of WAVE and is also chairing our meeting today, just as she did in October 2025. Antiretroviral therapy, treatment of viral hepatitis, and other issues related to the health of women living with HIV, as we know, fall within the scope of clinical and research interests of Professor Nina Weiss. And we are very grateful to the speakers and discussion participants from Europe. And we have a lot of participants who also support us. Dear doctors from Europe, thank you for continuing to support Ukraine. We would like to thank Dr. Martin Carponero, who works at La Paz University Hospital in Madrid, Spain, and she will be speaking today about metabolic disorders in women living with HIV, as well as Dr. Olga Tsahuridou, who works at the Aristotle University Clinic in Thessaloniki, Greece, whose topic today is cardiometabolic syndrome in women living with HIV, and Dr. Erica Ferrari, a postdoctoral researcher in infectious diseases with a focus on HIV/AIDS, who lives and works in Portugal, and she also will participate in our discussions. And these WAVE EX webinars on track to improve the health of women living with HIV Ukraine are just like a breath of fresh air in our daily work and challenging lives. We hope that the lectures and discussions will help us as doctors in Ukraine to improve care for women living with HIV in our daily practice. Ukrainian doctors' interest in the EX Wave webinar, which focuses on critical health issues for women living with HIV, remains high. A big thank you to the participants from Ukraine for continuing to work despite the difficult days and sleepless nights and the air raid alerts. Thank you for joining us now for our webinar. And we realize that it is important to take into account the needs of people living with HIV and to continue providing comprehensive care. Today, under martial law in Ukraine, this is even more crucial. This is a testament to resilience, consistency, stability that we also desperately need. And we're thankful to doctors from Ukraine, Angela Senchuk and Ina, and today's moderator will be Sergei Antoniak, a research fellow in the Department of Viral Hepatitis at HIV and HIV at the clinic of the Hromshevsky Institute, National Academy of Medical Science of Ukraine, and a member of the WAVE Scientific Committee. Thank you. Thank you very much, dear Svetlana. All right, what I suggest now, just I will outline briefly our agenda for today, and after that we will start our first mini lecture. So today we are going to talk about metabolic disorders in women living with HIV, and we will start from the lecture Metabolic Disorders in women living with HIV, presented by Dr. Luz Martin Carbonero from Spain, who works at the Internal Medicine Clinic and HIV Infection La Paz University Hospital, and also she is Associate Professor of Autonomic Madrid University from Spain. Dear Luz, thank you that you are with us. If you would like to say a few words, you're most welcome.
Okay, thank you very much for this kind invitation. Thank you to WAVES EACS groups that they are always making a great work with improving our treatment in women living with HIV. And also, of course, to Ukrainian doctors for being here and listening to me. Just 2 words to say that I've been working with people living with HIV for more than 20 years, and fortunately, I am looking how people are getting older, and women are also getting older, fortunately. That makes us think in any other problems that before we didn't think about that, as are metabolic problems and all these problems that are going to be greater during the next years. So I think that's a very important issue, and I hope you like my talk. Thank you.
Ми в цьому впевнені абсолютно, що вона нам
We
дуже
absolutely
сподобається.
sure that we will like your presentation. And after the first mini lecture, we are going to have just a short Q&A session. And just to remind you, dear participants, that you can write your questions to the chat, and we will look at them. And if we have enough time, we will talk about that. We will discuss that. And after that, we will switch over to our second lecture. For today, which is cardiometabolic syndrome in women living with HIV. That's going to be presented by Dr. Olga Tsakhouridou from Greece, Doctor of Medicine, Master of Sciences in Epidemiology, PhD, Assistant Professor of Internal Medicine, Chair, University Clinica HEPA, the Medical University, Aristotle University, Thessaloniki, Greece. Olga, if you would like to say a few words, you're most welcome. And thank you for being with us.
Thank you. Thank you for the introduction, and thank you for the honorable invitation to be a part of this session today. I would also like to thank Ukrainian physicians for working so hard this period. Honestly, it is really important to make sessions like that try to integrate the clinical management of HIV vulnerable population, and especially women, which are facing more problems, as we also seen yesterday as well, during their clinical healthcare receipt. So I believe that today we're gonna get a quick look of really important and significant things that will improve our clinical daily care. Thank you.
Дякую, пані Ольго.
Thank you, Ms. Olga. That's right. We are very thankful to you that you're with us today. Thank you. And after this mini lecture, we will also have a short Q&A session. So, dear colleagues, we will be waiting for your questions in the chat. And after that, if we have enough time, there'll be 2 clinical cases. The first one, managing woman living with HIV for 30 years, presented by Ina Lutsuk, infectious disease specialist, working at the Department of HIV Infection, the Institute of Epidemiology Infectious Diseases, named after Gromashevsky Medical Academy of Sciences. And the second one is about metabolic disorders in a woman living with HIV, presented by Dr. Angela Sainchuk, also infectious disease doctor, working at the same department at the Institute of Epidemiology Infectious Diseases, named after Gromashevsky. Academy of Sciences of Ukraine. So if you would like, you might say a few words. Thank you. Thank you for this opportunity. And thank you to all the doctors from abroad for your very warm words and for your support. Thank you very much. Thank you, Ms. Inna. And also, this is the second time over those 2 days. I would like to also greet Dr. Erika Ferrari from Portugal, Doctor of Philosophy, postdoctorate in the area of infectious diseases, hospital assistant at Unidad Local de Estuário de Tejo Estuárido do Tejo, Portugal. Erika, greetings to you. Thank you for joining us for the second day already. If you would like to say a few words, you're most welcome.
Hi, everybody. Can you hear me? So, thanks a lot for the invitation for the second day, and I'm very happy to be here. Okay. So I think you're going to have a good discussion today.
Так, дуже дякую. Дійсно, 2 дні
Yeah, thank you very much. Yes, yes, adherence. It means adherence because 2 days in a row participation is adherence. So, dear colleagues, I suggest we start our first mini lecture about metabolic disorders in women living with HIV from Dr. Martin Carbonero. You're most welcome.
Hello to everybody. First of all, I would like to thank the WAVES group in EACS for inviting me to give you this important problem as metabolic disorders in women living with HIV. Well, you all know metabolic syndrome is defined by many metabolic problems as are increase in blood pressure, fasting glucose, increase in triglycerides, and a decrease in HDL cholesterol, and an increase in the waist circumference and obesity. When three or more of these things are present, it is known as metabolic syndrome, and it is important because it is associated with an increase in cardiovascular disease, type 2 diabetes, and metabolic dysfunction of the liver, as is liver steatosis. It is very important among HIV people, and it is very much important because it has a higher prevalence compared with the general population. It is driven by IgE and chronic inflammation and immune activation, and because some antiretroviral therapy may contribute to these metabolic abnormalities. And it is very important in women because, as you all know, our HIV women population is getting older. You can see here that in Europe, median age of women living with HIV is between 45 and 50 years. That means that an increasing proportion of women are transitioning through menopause, and menopause will increase all these metabolic problems. As you can see here, one of the main reasons for death among HIV population is cardiovascular diseases. This is the red square that you can see here, and more than 8% of people nowadays in Europe and in North America living with HIV died because of these problems. And if we focus on what is happening in the general population, cardiovascular disease in women is the main reason of death in Europe. As our people is going to get older, probably this problem will increase in our HIV women. So that it is because it is so important. Even more, in women, cardiovascular problems are underdiagnosed, understudied, underrecognized, and undertreated. And this is because cardiovascular illness are a little bit different, have a little different presentation in women than in men, and are less studied. So we have to think in them more than we think in women, in men. What risk factors are important for these cardiovascular diseases in women? Of course, we have well-established risk factors as hypertension, dyslipidemia, obesity, or diabetes, but we also have sex-specific risk factors that are not well studied, like premature menopause, which is very often in women living with HIV, gestational diabetes, hypertensive disorders in pregnancy, and more. And what it is more important, there are social and psychosocial problems that are more prone in women, like violence, like problems, economical problems, socioeconomic depression, which also are associated with cardiovascular disease and are more often in women and even more often in women living with HIV. Menopause is crucial in cardiovascular disease because all these metabolic problems will increase. As you can see here, cholesterol, LDL cholesterol, and HDL cholesterol in women in the menopause are more similar than men than in the premenopausal women, and this will trigger all these problems. Well, we all believe that cardiovascular risk is greater in men than in women. However, in HIV-positive women, the protective effect of female sex on cardiovascular disease is reduced and even lost. As you can see here, cardiovascular diseases, these are men with HIV, these are women with HIV, these are men without HIV, and these are women without HIV. Cardiovascular diseases, as I have told you, in women living with HIV are very similar to men without HIV and are much more different of women living without HIV. So HIV is really a risk factor for cardiovascular disease in our women. We are now going to focus on some relevant risk factors in the HIV population. First, weight gain. During the last years, integrase inhibitors and TAF have been associated with an increase in weight gain in some studies. Here you can see the advanced study that you all know well, where an increase in weight was seen in HIV African women, African people, when treatment with when it was when they start treatment with dolutegravir, FTC TAF, an increase in weight was seen respect to people that started with TDF and efavirenz. And this problem, as you can see here, was double in women than in men. Women tend to increase more weight than men. Similar, in a cohort of North America, people living with HIV that switched to an integrase inhibitor, the blue line here, as you can see here, tend to gain more weight than people that were still with the same treatment without integrase inhibitor, the red notes, and people, HIV negative people. So people with integrase inhibitor tend to gain more weight. And again, it was greater in women than in men. So the effect of the weight gain can be different in women than in men. However, there are many doubts about if integrase inhibitor or are recent studies have shown different results. And for example, in this study that was performed by Merck, what they saw is that people who were with undetectable viral load were randomized to switch to dolutegravir plus islatravir or to switch to bictegravir FTC TAF. And after 1 year of follow-up, people that were without integrase inhibitor, as you can see here, didn't weigh more weight. And the same happened with people with bictegravir. So there were no difference among both arms. So in this study, integrase inhibitor was not associated with an increase in weight compared with regimens without integrase inhibitor. The same was seen when we saw cholesterol, LDL, or any other parameters associated with metabolic problems. What I want to see is that nowadays we still have some doubts of the effects of integrase inhibitors in weight when we compare with new treatments. Well, another important problem is in women and is metabolic associated steatohepatitis. It is known that it is increased in people living with HIV. This is a great meta-analysis that was performed when a review of 33 studies was performed, and more than 8,000 people entered in the study. And what it was seen that it was that nearly 1/3 of people living with HIV had liver steatosis, and nearly 12% have fibrosis. So this is of great concern. And this is of great concern, even though in women, it was shown that metabolic disease related with liver disease tend to be lower in women than in men. However, this, again, when menopause arrives, tend to be similar than in men. As liver steatosis increase with age in women, which is the red line, and is more similar of what we see in men. And of course, you all know that liver steatosis is associated with a greater risk of cardiovascular disease, greater death for cardiovascular reasons. It is associated with progressive liver fibrosis and cirrhosis. It is associated with hepatocellular carcinoma and of course with type 2 diabetes. Another problem with menopause is that it increases insulin resistance. This was a study that was performed in the United States. They wanted to compare if people with integrase inhibitor, women with integrase inhibitor, compared with women without integrase inhibitor, had more insulin resistance that was measured by HOMA. And what they saw is that when we see women in the late perimenopause or in the perimenopause, these both lines that are people living with HIV increase their insulin resistance in both groups without integrase inhibitor and group with integrase inhibitor. And this was much different of what was seen in non-HIV women. So menopause, again, makes a risk of insulin resistant, and this is greater among HIV women, even and it doesn't matter the regimen that they were taking. So what we can do? Well, we have to estimate cardiovascular risk factor in our population. We have to try to fight against all those risk factors. And we have to think about cardiovascular disease when our women tell us clinic that is compatible with heart attack or with any other cardiovascular problem. How do we estimate cardiovascular risk? This is a great question because we don't have the answer. Of course, we have these calculators that this is the American Heart Associated Heart Calculator for cardiovascular risk. And you can put here all the characteristics of our women, age, race, whatever. And here a risk will calculate if this risk is greater than 5% or greater than 7.5%. This is a great risk factor, and we have to fight against it. However, we know that cardiovascular risk factors underestimates the risk prediction among HIV women. You can see here in the REPRIEVE trial, here is the women, and you can see here that women had more observed cardiovascular events that were expected by the risk estimated by our risk calculator. So this risk calculator underestimates the risk factors, the real risk of women, and we have to be careful with them. And what can we do? Well, EACS guidelines tell us that we have to fight again, we have to change lifestyle, do lifestyle interventions. We should study cardiovascular disease and treat blood pressure and whatever. We should treat diabetes mellitus, dyslipidemia, and an important point talks about weight gain and obesity. We all know that statins in the REPRIEVE trial have demonstrated that if we use statins very early, we can prevent cardiovascular events half of the times. And it is the same in women. Pitavastatin decreased the risk of cardiovascular event 50% in those women that were receiving pitavastatin when were compared with placebo. I would like to stop a little bit with obesity. Of course, the most important is lifestyle interventions, and a diet and exercise is one of the main things that we can do. However, you all know that this is very difficult sometimes to do. No, sometimes to convince our patients to make these lifestyle interventions. We also, but we now have other tools, are drugs with GLP-1, and the EACS guidelines tell us that these drugs are secure in HIV people, and beyond weight loss, these agents have shown benefits on insulin resistance, inflammation, hepatic steatosis, sleep apnea, alcohol dependence, and many other conditions. So sometimes we can think about these drugs because they can help our patients to lose weight, sorry. Well, another important, very, very important thing that we can do is try or explain our patients how important is that they stop smoking. And we have also tools and drugs that will help them to stop smoking, but it's important to remember them how important is this problem. So to conclude, I would like to say that metabolic disorders are growing concerns among women living with HIV. It is especially when they become in the menopause. It is one of the leading causes of morbidity and mortality. Early diagnosis and appropriate management are essential, particularly during menopause. Diet, exercise, smoking cessation, and managing of other risk factors are essential. And to date, we do not have enough data to support the use of one antiretroviral treatment over another. Thank you very much for your attention. I would like to leave this talk with one picture of Maruja Mayo, which is a very famous Spanish painter from the last century. Thank you very much for your attention.
Дуже дякуємо.
Thank you very much. We are very grateful to you, Dr. Martin Carbonero, for this very interesting
І дуже інтересну доповідь щодо метаболічних розладів.
inspiring lecture on metabolic disorders. And we understand that metabolic disorders is a very significant complication. And we know that as being doctors working with women with HIV, living with HIV, and there are hormonal factors and some periods of women's life when the risk is higher. We understand that we need to do metabolic diseases screening, and this screening has to be on a regular basis and provide care. And the best is multidisciplinary approach, of course. And of course, we would love to have cooperation with experts like you, for example, who know a lot about metabolic disorders. So thank you very much, Dr. Luz Martin Carbonero, for this lecture.
Okay, you are welcome.
Так, дуже дякуємо. Насправді у нас доволі багато
Yeah,
запитань
thank
є
you very
в
much.
чаті
In
від
fact, we
наших
have quite a lot of questions in our
глядачів,
chat
від наших
from our
учасників.
participants.
І перше запитання
And the first
судячи з
question
усього, від того, хто приймав участь і вчора, тому що
is
воно
probably
поєднує
from
тему
one of
наших
the
двох днів.
persons
Звучить
who
наступним чином.
listened to yesterday's
Прокоментуйте,
webinar.
будь ласка,
So
вплив
comment,
порушень
please,
ментального
the
здоров'я, наприклад,
impact on mental
депресії,
health
хронічного
disorders
стресу
like
і інші
depression,
на
chronic stress,
метаболічні
or
розлади.
others, how they impact the metabolic disorders.
Well, that is a very, very good question because psychiatric and psychological problems have a great impact on cardiovascular disease and also metabolic problems. First, because sometimes it is associated with any other risk factors, like, for example, smoking or drinking alcohol and all this that will increase the risk of cardiovascular events. Also, because some psychiatric drugs make increasing weight and increasing also cholesterol and whatever. Because also, as I have shown you in one slide, stress, economic problems, psychological problems also makes you more stressed, and this will will increase your cardiovascular risk. And also, I think it's a very difficult to treat population because they have a lot of many other problems. So you have to focus probably on these problems that in this moment are more important. And sometimes you don't think as much as cardiovascular risk factors or to treat with statins or whatever, because you have to focus first on other things.
Дякую, Луз.
Thank you, Luz. And dear participants and dear chair, do you have any comments or questions?
Well, if may I ask a question? Thank you, first of all, to Dr. Martin Carbonera. It was a really impressive and fantastic overview of the situation regarding cardiometabolic diseases in women living with HIV. I was interested in two things. And the first is, how do you screen your patients in your clinic? How much do you do regarding screening for cardiometabolic diseases in women living with HIV?
Well, thank you for the question.
Дякую за це питання.
We measure all time blood pressure, all time they came to clinic. Of course, we ask about the smoking. This is very, very important and it is very important to repeat and repeat that they should stop smoking. Because if you tell once, probably they won't stop smoking. But if you tell once and twice and three, and you explain that we are seeing a lot of cardiovascular events or cancer or whatever, you obtain some results. So this is the first thing you have to ask and to get advice about this. And we always, as I told you, measure blood pressure. And if it's high in the clinic, we make them measure at home because sometimes it changes, or we make a 24 hours measure of blood pressure. And we also measure always twice a year cholesterol, lipids, glucose, and all these things. And we usually use these tools that I have told you as the cardiovascular risk factor calculators, although they are not very precise, but they give you a little bit, you can, well, there's something that helps you to know if they are with high or low cardiovascular risk.
Thank you so much. And I
Дуже,
agree
дуже.
very much with you that the problem to get everybody to stop smoking is continuous. It's just going on and on, it's ongoing. And also very sadly, I have some patients who, I've talked with them about the smoking situation for many years, and they didn't stop, and they have also passed away. And I think maybe we will experience this with our patients as the group of patients living with HIV, they age. So I think that's a very important issue, and we can maybe discuss it when we have time in later on. My second question was regarding pitavastatin from the Reprieved trial, whether do you use that for everyone, or how do you do that in Spain?
Well, that's a very good question again. I know some guidelines, as English guidelines, recommend pitavastatin over 40 years for everybody. In my opinion, and what we do in clinic is that it is probably too much. What we normally do is make calculate the risk, and if it's greater than 5%, we always advise or propone to give this patient any statins. We use pitavastatin, or we use rosuvastatin, or atorvastatin, because in Spain it's cheaper. And if one person has very low cardiovascular risk, like 2.5%, we normally wait. And unless it's over 60 or something. I think age is important also. So to conclude, in Spain, Spanish guidelines tell us, if it's greater than 5%, start a statin. And if it's lower than 5%, just think about it. So in that way, we talk to the patient. I think age is important. If it's elder than 60, I am more prone to give a statin. And what life has he now? If he smokes now, if he has smoked, I don't know. There are many things that you have to balance. That's what do you do? Because I think it's
no. I do the same, and we in Denmark we don't give pitavastatin to everyone, but we are of course aware of if patients have high cholesterol. But I think it's again we go back to the very important issue of smoking. I think also physical exercise, the diet. There are lots of things that you can do before you start a statin, and usually we give the patients kind of 3 or 6 months to try to change the lifestyle to see if that works. It doesn't work for everyone, but for some it does, and then they shouldn't start medication, I think.
Mm-hmm.
Thank you very much.
Thank you.
Дуже дякую, колеги.
Thank you really very much, colleagues. So we have lots of questions in chat, and other methods of communication are also involved and engaged. And this is going to be a question to Luz and other participants. So what scale of cardiovascular risk assessment is better for women living with HIV, like SCORE2, DAD, or some other system?
Well, I think there are controversies with all these risk cardiovascular calculators. We use very much the American, even though European people is different, and especially Spanish people is different, because we have Mediterranean dieta, not exactly, but more Mediterranean dieta than the American people, and this is better. I mean, but what we like about, I think each doctor use one cardiovascular calculator or another. I like the American calculator because it is the one that has demonstrated in Reprieve trial that prevents these risk factors, that prevents events. But I think, and especially for women, we have to improve these calculators, because they underestimate, all of them underestimate risk factor in women. I don't know my other colleagues what think.
So I agree with you, because we have a chronic inflammation in these patients. And the problem with the women is just because even with this inflammation, even with a virologic control, this inflammation stay during the time. And the other problem is the menopause, that when a woman is getting into this phase of life, the cardiovascular risk is going to increase, and because of the hormonal changes. And we have to, I think it's better when we start to do lifestyle interventions in this population before the age of 50. Because I really see in my clinical practice that the women at menopause have so many problems with obesity and dyslipidemia. So it's not just because of the lifestyle, but we know that menopause is going to worsen some things.
May I also add to Erica's comments? I agree with you totally, Erica, but at least at my country, also late presentation of women is also a significant factor for this excessive phenomenon of metabolic syndrome in women. It's very common that women are diagnosed at the very late stage compared to men in Greece, and this means that they have added years of chronic inflammation, and so when they come to treatment, when they are linked to care, they already have metabolic problems, and of course menopause is deteriorating this phenomenon.
Thank you so much for your answers. Thank you for this wonderful discussion. Now I need to keep an eye on time. We still have a lot of questions, but we will be able to tackle them later on. What I suggest is to move on to our second lecture for today, and after that we will continue with our discussion. And this lecture is on cardiometabolic syndrome in women living with HIV, and this is going to be from Dr. Olga Sakhuridou.
Good afternoon, everybody. Today we will address a clinical challenge encountered with increasing frequency in daily practice, i.e. cardiometabolic syndrome in women living with HIV infection. Women, as we all know, account for at least at approximately 1/4 of all people living with HIV in the US and over 50% of all people living with HIV worldwide. In the European region, however, 50% of women with HIV are diagnosed late, with women in their 40s being 3 to 4 times more likely to experience a late diagnosis. This prolongs the duration of uncontrolled systemic inflammation prior to initiating treatment. The success of antiretroviral therapy now has transformed HIV into a manageable chronic condition. However, this has shifted our therapeutic focus from opportunistic infections to non-communicable diseases like cardiovascular disease and metabolic syndrome. In women, this challenge features unique characteristics: pathophysiological mechanisms, drug-drug interactions, drug-specific toxicities, and hormonal shifts converge to create a distinct risk profile that demands targeted clinical vigilance for this vulnerable population. Cardiovascular risk also is a 1.5 to 2 times higher risk in people with HIV, and mainly women, and the risk is often more pronounced and disproportionately high in women compared to men. Let us examine now the data. Women living with HIV present up to a 3-fold higher relative risk of myocardial infarction compared to HIV-negative women. Here we observe a distinct gender paradox. While in the general population men carry a higher cardiovascular risk at a younger age, the HIV attributable spike in cardiovascular disease is significantly more pronounced and disproportionate to women. The primary now clinical pitfall is underdiagnosis. As already said, traditional risk calculators such as Framingham risk score systematically underestimate cardiovascular risk in these women because they fail to account for the underlying chronic inflammatory burden. Thus, we have this racial paradox and the common underestimation of risk by classical tools already used. But why does this occur, and why does this happen mainly in women? The pathophysiology is multifactorial, as could one say. Even under optimal virological suppression with an undetectable viral load, persistent low-grade systematic inflammation and immune activation remain. Biomarkers like interleukin-6, TNF-A, and soluble markers like CD14 and CD163 remained elevated. This chronic inflammatory state drives the endothelial dysfunction and accelerates pathogenesis of atherogenesis, resulting in an unstable, non-calcified coronary plaques that are highly vulnerable to rupture. Concurrently, both the virus and ART cause adipose tissue dysfunction, promoting ectopic, visceral, and pericardial fat disposition, which directly drives to insulin resistance. And this is why are women at higher risk. Here you see the inflammatory pathway that has to do with the chronic systematic inflammation and persistent immune activation despite the virological suppression. Furthermore, adipose tissue plays a role by the changes in adiposines that promote insulin resistance. And with regards to premature reproductive aging, earlier onset with menopause, which increases the cardiovascular risk in women, and as already said, endothelial dysfunction that accelerates atherosclerosis due to the combination of HIV and metabolic disorders. But what is the cardiometabolic syndrome definition? Just a quick look through the definitions as proposed by the National Cholesterol Education Program and the National Diabetes Federation. We should have a combination of high blood pressure, a high waist circumference, elevated LDL cholesterol, and the situation and condition of pre-diabetes or diabetes with impaired hemoglobin A and A1C and fasting plasma and impaired fasting plasma glucose. With regards to clinical manifestation and comorbidities that are linked to the cardiometabolic syndrome, we have increased coronary artery disease in these patients. We have ischemic stroke that accounts for more than 80% of strokes in this group. We have liver metabolic related steatosis, and of course conditions that are related to metabolic syndrome and exacerbate osteopenia and renal dysfunction. The sequelae of this syndrome impact multiple target organs, as you can see. In the pericardium, we frequently observe this left ventricular hypertrophy and an increased incidence of heart failure with preserved ejection fraction. In the liver, as already mentioned, we have metabolic dysfunction that drives to metabolic dysfunction-associated steatohepatitis, which processes significantly faster towards fibrosis and cirrhosis in women living with HIV. Lastly, the kidneys face a dual hit from the metabolic complications of accelerated diabetes and hypertension, compounded by potential residual nephrotoxicity from historical ART regimens. But what about hormonal factors and premature menopause? Let us see what is happening with women, with female population living with HIV. The hormonal anomaly is critical variable. Women living with HIV enter menopause an average 1 to 3 years earlier than the general population. This premature ovarian insufficiency deprives them from the cardiovascular benefits of endogenous estrogens at an earlier chronological age. The abrupt now decline in estrogen levels triggers a sharp metabolic shift. It elevates blood pressure, worsens insulin resistance, and redistributes the adipose tissue centrally, leading to a rapid increase of weight circumference. And this results in important health changes like weight gain, cardiovascular risk, and bone loss. Most women now with menopausal symptoms do not receive effective approved evidence-based therapy, which is also a really important obstacle. And here we see the biophysiological impact, the menopause timing, and the symptom burden of severity of women with HIV in menopause. Obesity is also more common in women than in men with HIV in the US. And here we see the prevalence of obesity among people with HIV in three different US-based cohort studies stratified by sex. And as we see with the purple bars that represent women, you see that in these three studies, obesity is more common in females. Weight gain is also more common after starting ART. ART are now associated, gain weight is associated with cardiometabolic effects in women with HIV, as we can also see in this recent study published in 2020. What about now the comparison of the metabolic side effects by ART classes? Here you see this table with the impact of ARVs in the metabolic syndrome in HIV. As you can see, different ART classes have different impact on weight gain, dyslipidemia, and insulin-resistant diabetes. Integrase inhibitors, as we all know, they have highest risk of rapid initial weight, low to moderate impact on dyslipidemia, and they are linked to adipose tissue dysfunction. Protease inhibitors have mainly peripheral fat loss and track weight, but they have a significant increase in triglycerides and LDL cholesterol, while they have a direct inhibition of GLUT4 transporter. With regard to non-NRTIs, we know that doravirine is weight neutral. Efavirenz also increases total cholesterol, but the impact on insulin-resistant diabetes is minimal. But what happens in females? Here you see that integrase inhibitors have a severe impact on women with a double higher risk of obesity versus men. PIs aggravates postmenopausal lipid profiles in women, and non-NRTIs have a lower metabolic burden overall. So at this point, let's make a small summary. Overweight and obesity are common in women living with HIV. Obesity is associated with several health complications. Weight gain in women living with HIV may be also related to ART classes and menopause. And let's see now how we can reduce cardiovascular risk in women with HIV. And let's have a quick look through the guidelines and the REPRIEVE study. The 2013 American Heart Association pooled cohort equation that calculates the risk for cardiovascular disease may underestimate the risk in women living with HIV. Fortunately, we have new heart disease risk calculators that incorporate and take into account more variables and more parameters in order to further and better calculate the risk of heart disease for women. Let us pivot now to the most practice-changing clinical data in the recent years, the REPRIEVE trial. This study fundamentally altered the standard of care, demonstrating that initiating pitavastatin calcium at the dose of 4 milligrams daily in HIV-positive individuals with low to moderate cardiovascular risk reduced major adverse cardiovascular events by 35%. The pivotal finding here is that the clinical benefit was entirely independent of the baseline LDL cholesterol levels. This is due to the potent pleiotropic and inflammatory properties of the statins. The clinical guideline now is clear. In women living with HIV over the age of 40, the threshold for statin initiation should be extremely low, regardless of whether traditional scores categorize them as low risk. And so this is the fundamental publication that proved that 4 milligrams of pitavastatin daily lowered the risk of major adverse cardiac events by 35% compared to placebo in people living with HIV and that didn't have any underlying heart disease. Managing now these patients requires meticulous attention to drug-drug interactions because as the AIDS processes, we have polypharmacy in many people living with HIV and increases, of course, with AIDS. So it is important to take into consideration and have a deep knowledge of the drug-drug interactions in our clinical management algorithm. When prescribing now cardiovascular medications to women living with HIV, The foundational clinical rule is to check for the presence of CYP3A4 cytochrome boosters inhibitors within their antiretroviral regimen. With regards to beta blockers, carvedilol is the preferred agent. We have to be very thoughtful when prescribing calcium channel blockers, because drugs like amlodipine or diltiazem show markedly elevated plasma levels when co-administered with boosted ART regimens due to the CYP3A4 inhibition requiring down titration. If now rapid waning weight occurs post-INSTIs or TAF initiation, we should consider switching to TDF or metabolically neutral regimens, or for example, for established obesity and insulin resistance, GLP-1 receptor agonists show robust efficacy in this population. With regards now to antiplatelets, we should be very cautious, especially with clopidogrel, which has a high clinical alert, since it is a prodrug requiring stepwise biotransformation and activation through these cytochromes, and of course protease inhibitors and boosters block this activation pathway, drastically reducing the efficacy and increasing the risk of stent thrombosis or ischemic stroke. Similar caution should be taken with prasugrel and ticagrelor, and it is these agents are strictly and absolutely contraindicated with certain antiretrovirals. So the clinical solution is that if we have a patient on a boosted ART regimen that requires your antiplatelet therapy, for example, following an acute coronary syndrome, the safest approach is an immediate ART switch to a booster-free regimen, for example, unboosted INSTIs, allowing the safe use of clopidogrel or ticagrelor. When a woman with HIV exhibits rapid weight gain, more than 5% of total body weight within the last 6 months, or escalating metabolic syndrome, modifying ART regimen should be actively pursued, providing virological suppression that can be securely maintained. So let me present you 3 strategies that are proposed from literature in order to manage this phenomenon. The first strategy refers to the de-escalation from tenofovir alafenamide to TDF, provided renal function is normal and bone mineral density allows it. The clinical benefit of this strategy is that the TDF exhibits a proven lipid protective and weight neutral profile, frequently resulting in a reduction of total cholesterol of body weight. The next strategy is the transition to a two-drug regimen, as already proposed by the latest guidelines. The intervention refers to switching the patient to the dual regimen dolutegravir-lamivudine, with the clinical benefit that completely eliminates the TAF component, thereby decreasing the overall metabolic burden while maintaining a high genetic barrier to viral resistance. And the third strategy is to switching from INSTIs to doravirine, the most commonly used non-NRTI agent, by replacing the integrase inhibitor with the modern next-generation non-NRTI doravirine. We have the clinical benefit that the doravirine possesses the most favorable metabolic profile among contemporary antiretrovirals, demonstrating zero gain weight signal and favorable lipid changes, make it an ideal choice for women with established cardiometabolic syndrome. And so let's move on to the guidelines for screening, diagnosing, and monitoring for cardiometabolic condition in HIV patients. It is important for us in daily clinical practice to use screening protocols that assess cardiovascular risk factors with assessment of blood pressure, lipid profile, fasting sugar, and body mass index, using specific diagnostic criteria as proposed by the current guidelines. Also important is the screening of metabolic complications by clinical evaluation and laboratory testing for dyslipidemia and insulin resistance, using periodic clinical evaluation and laboratory testing. So the treatment algorithm for the clinician comprises from the screening, the ART optimization, and the use of contemporary therapies. With regards to the screening, we have the annual lipid profile, the hemoglobin A1C testing and waist circumference measurement. With regards to the ART optimization upon rapid gain weight, and this is important to mention that the time that once one gains weight is really important in order to take action. We should consider replacing INSTIs or TAF with TDF or milder metabolic regimens. And also, early use of GLP-1 receptor agonism has proven to be critical for the management of obesity and insulin resistance in women living with HIV. And here you see a flowchart guide for an integrated approach to cardiometabolic management in HIV women. And in the left, you see the lifetime modifications that might help us improve the cardiometabolic conditions in HIV women. And on the right, the pharmacological tools that we have in our hands in order to improve the cardiometabolic condition of an HIV women. With regards to diet, we should adopt an anti-inflammatory Mediterranean diet rich in fiber and omega-3 fats. With regards to physical activity, at least 150 minutes of moderate aerobic exercise per week is suggested in women living with HIV, and the sedentary lifestyle and poor diet doubles the likelihood of obesity and hypertension in this group. However, we have certain challenges and barriers in the management of cardiometabolic conditions in HIV women, like socioeconomic barriers, stigma, and healthcare disparities that prevents women from reaching care and impairs adherence to ART. The impact also of antiretroviral therapy on metabolic health, as already seen, is really important. We have certain inflammation and metabolic alterations, smoking and lifestyle modification also playing a significant role, and of course, women face certain research gaps and future direction need to be taken by incorporating more women in real-world studies. To conclude, I would like to leave you with some specific takeaways. Women living with HIV exhibit an aggressive, accelerated cardiometabolic risk profile driven by the synergy of viral inflammation, ART toxicities, and premature menopause. The REPRIEVE trial establishes statins in primary prevention for the majority of patients over 40 years old, irrespective of baseline LDL levels. Universal screening of CYP3A4 mediated drug interactions is mandatory prior to prescribing any cardiovascular or metabolic pharmacotherapy. Coordinated care is also important and essential by collaboration between infectious disease specialists, cardiologists, and endocrinologists in the management of women living with HIV. Management should also take into account the hormonal profile and the woman's stage of life by individualizing therapies for every woman living with HIV. And of course, early intervention in 2026 saves lives and ensures healthy aging. Thank you.
Ольга, дуже дякую. Ніно,
Olga, thank you so much. Nina, would you like to start?
Yes, thank you. Thank you, Olga, for this excellent presentation and overview. I have learned a lot already. And I have just a few questions because I think both the previous speaker and you referred to the REPRIEVE study. And there is always a huge difference between a clinical trial with a very highly selected group of patients, and then when you go out into everyday life in a lot of different countries with a lot of different other factors also having an influence on the cardiometabolic syndrome. So my question to you is, I understand that you follow guidelines and you are very careful with prescribing statins in any kind of statins. But have you explored the adherence to this treatment? Do you think that patients with HIV who have a lot of other issues going on in their lives, do you think that they actually take the statins every day? Have you investigated that? That is my first question.
Thank you for the question. We are planning to publish very soon some data from our clinic with regards that the patient that, according to Reprieve, would be eligible to start a statin or should start a statin, and what happened through a five-year observation if they started a statin and if they were adherent to statins, and what were the results in cardiovascular events. So truly, it's very difficult, the data from organized studies, RCTs, to real world studies, because definitely we see poor adherence to study uptake. Also, there is at least in my clinic, there is much hesitancy from patients starting a statin. I don't know. I would like to hear your experience on that. They are so hesitant on taking another drug, another chronic drug. They are very anxious about the possible adverse events of the statin. So adherence to statins is truly, I would say, poor, even to those that are at high risk for cardiovascular disease. So yes, this is true. Real world is totally different from organized studies. However, unfortunately, we face many problems and many unhealthy patients with HIV, and especially women. At least from my experience, women are really affected from cardiovascular disease and metabolic syndrome. So we should totally try to work on this part, the adherence and the uptake of statins, and all the measures that already been presented from me and the previous speaker, that we should follow an integrated approach to these women. And of course, support, psychological support is really important in this population.
Thank you for that excellent answer. I think this is a very important and very critical discussion, because one thing is that there is a very good study, but the other thing is in our everyday clinical life, and maybe we can also discuss this a little bit later. And I think another thing is, you say that you are going to publish your data very soon from an observational study. And one thing is the eligibility criteria for patients. But the second thing is the barriers to start the medication, both maybe from the patients, but also sometimes from the treating physician. So how do you measure, eligibility, I think that's easy to measure in a neutral way, but how do you measure adherence?
Unfortunately, adherence is something also underestimated, I think, and it's hard to measure. We don't have, in other settings in low-income countries, you can measure the adherence to ART by the number of drugs being left behind. But unfortunately, in our daily practice, this is not easy to assess and not easy to confirm. For example, you ask the patient at each visit, do you take your medication regularly? He says or she says, yes, I do. I never forget the doses. But at the end of the day, when you check the prescriptions history, you see that she hasn't or he hasn't get a prescription for statin for at least 1 or 2 months gap. So it is really difficult to measure adherence and to assess the result of a successful intervention like statin onset. So I think we have much work to do on this field as well. It's really difficult, and all the data should be discussed with caution.
I agree with you. And my last question, and then I'm sure that there are a lot of questions from the chat as well. My last question is it the treating physician who decides whether the patient should start statin, or do you have a kind of outpatient clinic conference or an multidisciplinary team conference, or how do you do that in Greece?
I've been in this clinic for more than 16 years, and truly the way we treat patients and we take the decisions has changed dramatically. In previous years, at the beginning of my involvement in HIV, we used to be at really strong collaboration with other specialties, and we were trying to arrange all the visits to other specialties by ourselves. Now we don't have this opportunity, and we allow patients to visit their physicians and to be confident to choose their physicians. So we make the suggestion. We check all the variables, all the parameters that are necessary in every visit, but we normally don't make an appointment with other physicians to make a shared decision for a statin onset. So we make the suggestion. We also ask the patient to visit the cardiologist, for example, and discuss the opportunity. We also advise our patients not to hide the ART intake, because many people do that, and especially women. They don't want to disclosure HIV infection and the uptake of ART. So it is important for other physicians to know who is exactly the patient we have opposite of us. For example, according to Reprieve, we suggest the statin uptake to many people, that their cardiologist has, of course, disagreement on that, because he's not aware of the ART and the HIV infection. So it is important to collaborate with other specialties in order to make a more precise clinical management of these patients.
Thank you very much. And I think I will pass the word on to you again, Sergey. Thank you.
Thank you.
Дякую, Ніна. Дякую, Ольго.
Thank you, Nina, and thank you, Olga, for wonderful presentation, for wonderful answers. And we really do have some questions from our chat. We just discussed that, yes, we use different statins in our practice. And the question is, what kind of statins are better for women, women with HIV and women in menopause?
Okay, this is a very good question. It really depends also on the RT drug women take at this point. We know that pitavastatin and rosuvastatin have minor drug interactions with most of the RT agents, so these are the most commonly prescribed and prefer the statins that we use in our daily practice. However, we should use with caution all other statins always having in mind which is the patient opposite of us. So it really needs a workup. It really needs a workup on the rest history of the women. Of course, if a patient is on a boosted PI with a return of viral complicity, that simvastatin and lovastatin are strictly contraindicated, as we all know, due to the imminent risk of rhabdomyolysis. So we also we should have in mind that atorvastatin must be initiated at the lower dose with a strict cap at 20 to 40 milligrams, so we can escalate the dose with close lab monitoring. Conversely, pitavastatin is the safest option because it doesn't rely significantly on the CYP3A4 pathway for metabolisms. So we should take in mind that we can use several drug classes on the statin from the statin group. However, we should differentiate in the laboratory and the clinical management of these women.
Зрозуміло. Дуже дякую.
Thank you very much.
Так, пані Луз, пані Еріка, може, у вас є коментарі?
Ms. Luz, Ms. Erica, do you have any comments or questions to Olga? If not, then we will switch over to our cases. So if you do, please, you can go on.
So I think you can go to the clinical case.
Добре.
All right. In this case, switching over to our first clinical case, which is clinical management of a woman living with HIV for 30 years. And Inna Lutsuk is going to present.
Greetings to all of you. My name is Inna Lutsuk, and I'm an infectious disease specialist, and I work at the Department for Patients Living with HIV at the Epidemiology and Infectious Diseases Institute named after Gromashevsky. And today I suggest to talk about a woman who's been living with HIV for 30 years. So the story about Tatiana. Tatiana is 57. She has higher education and has been living with HIV for 30 years. HIV infection was diagnosed in October 1996 when she was 27. And since 2002, for 23 years, she has been receiving ART continuously. And since 1992 to 1997, she used injectable drugs, opioids. And from 1997 till present, she withdrawn from drugs. She has not been using drugs for over 28 years. She participated in the 12-step program, and she graduated from a teacher's training institute via distance learning with a degree in practical psychology, and now she has a private practice since 2010. So she's been living with HIV for 30 years, and she's been taking ART for 23 years. With regards to opioid dependence syndrome, currently she's in remission, has not been using drugs for 28 years, does not smoke, does not drink alcohol, unmarried, sexually active. Contraception is barrier methods, but she does not use them always. STIs, none, and never had any. 2 pregnancy nullipara-induced abortions too. At the age of 51, she had menopause, started to have menopause with a diagnosis menopausal and female climacteric states. Hormonal replacement therapy started 3 years ago, and she's currently on it. Transdermal estradiol, estrogel, and levonorgestrel containing intrauterine device Mirena. And Tatiana is 57. In 2008, Tatiana became the legal guardian of a 10-year-old boy named Oleksiy. Oleksiy has been living with HIV since birth. He was raised in an orphanage for babies and then in a regular orphanage. Oleksiy's birthday in 1997 coincides exactly with the date Tatiana began her sober, drug-free life. And today, Oleksiy is 28 years old. With regards to opioid dependence, Tatiana is in remission for 28 years. And also, her son runs a business, works hard, he's successful, and Tatiana is proud of her son and loves him. For many years, they lived together as a family, but it has been 2 years since her son bought his own house and moved out. And Oleksiy was born to a mother living with HIV. It was her first pregnancy. She died shortly after giving birth. Oleksiy grew up in a special orphanage for babies and later in a regular orphanage. At age 4, Oleksiy was hospitalized due to progressive HIV infection, where he met his future mother, Tatiana. And at age 4, Oleksiy's CD4 was 175 cells, 7.5%, HIV viral load 7 million. And since 2002, Oleksiy started ART and his first regimen, DDI, D4T nalfinavir, second ART regimen, DDI, D4T lopinavir, ritonavir, and due to lipoatrophy, he was switched after AZT3TC plus lopinavir, and the fourth regimen, TDF-FTC plus raltegravir, and the fifth ART regimen that he's been on since 2023, TAF-FTC dolutegravir, and he is currently taking this regimen. Alexei has lipoatrophy as a side effect of the old ART regimen. So his lab work as of March 26, CD4 459 cells, 33% viral load is undetectable. And with regards to Tatiana's HIV-related health, her HIV infection was diagnosed in October 1996, and she sought treatment at HIV clinic in 2002. Her CD4 count at that time was 398 cells, 14%. In April 2002, she was diagnosed with a TB in the right upper lobe. Standard treatment was administered. With regards to HIV, diagnosis HIV infection, clinical stage 3, and newly diagnosed TB of the right upper lobe, depressive disorder. She started ART, ACT, 3TC, abacavir, and at that time, she bought this regimen from the Baltic states, and as long as she wanted to take this regimen, it was one pill regimen, she started on this regimen, but 6 weeks later, she developed side effects, namely anemia, and due to that, lamivudine, zidovudine was stopped because her hemoglobin was 48, and she developed the hypersensitivity syndrome due to ABC, and she had body temperature up to 39 Celsius, shortness of breath, and her condition was worsening with each pill. ART was stopped, lamivudine, zidovudine, abacavir was discontinued and withdrawn. And Tatiana was getting the following ART regimens: zidovudine, lamivudine, abacavir, and due to that she developed anemia and hypersensitivity. She also was getting D4T, lamivudine, and lopinavir, ritonavir, and she also was getting lamivudine with lopinavir, like two-drug regimen, and in 2009 tenofovir, emtricitabine, lopinavir, but she had a side effect to lopinavir. She had diarrhea 7-8 times a day, and due to that she was taking loperamide, and also she had occasional nausea, and since 2013 till now she is on ART regimen, and that is TDF-FTC raltegravir regimen. Her viral load is undetectable, and her CD4 count is 477 cells, 31%. That was as of March 2026. Tatiana's history of hepatitis C. In March 2004, hepatitis C antibodies detected, PCR was positive, genotype 3AB, and her treatment was with pegylated interferon and ribavirin. That was lasted 16 weeks. And she couldn't complete this course due to toxicity. In September 2008, she was tested again, PCR, Hep C PCR with positive result, and this is type 3AB. In 2015, when access to direct-acting antivirals became available in Ukraine, she was offered to treat Hep C. And antibodies to Hep C were positive, PCR for HCV negative result, FibroScan F1, and 6.8 kilopascal, and she spontaneously cleared Hep C. And this is the history of depressive disorder. She first started taking antidepressants in 2008 following a traumatic experience. She lost of her 2 loved ones, and she was counseled by a psychiatrist. Paroxetine was prescribed 20 milligrams in the morning, and she took the medication for 2 years. During treatment with paroxetine, condition improved significantly, but frequent mood swings persisted and at times aggression. Her weight increased significantly. She gained about 10 kilos. And then she came to see a psychiatrist a second time in 2021 when symptoms emerged again following a string of mishaps. And she had mood dropped significantly, reduced ability to function, became indifferent to everything, became apathic, unmotivated, and she neither had strength nor desire to work, but no psychotic symptoms detected. On hospital anxiety and depression scale, she scored 5 points for anxiety and 13 points for depression, respectively. And based on the patient's medical history, clinical examination, and test results, the following diagnosis was made: recurrent depressive disorder, current episode moderate, and treatment escitalopram 10 milligrams in the morning. Her condition gradually improved, but with the beginning of war in 2022, Tatiana moved out to Poland, where she was on and off her antidepressant medications. And in late December 2023, Tatiana returned to Ukraine. She complained of 8 kilo weight gain and unstable mental state. Escitalopram was discontinued and fluoxetine was prescribed in the morning, 20 milligrams. Her mental state gradually improved, and currently Tatiana continues to take 20 milligrams of fluoxetine in the morning, feels well, and is working in her field. As long as military operations continue in the country, discontinuation of the antidepressant is not being considered. Tatiana has been living with HIV for 30 years. She is now 57. She's been receiving ART continuously for 23 years. For 13 years, she has been on TDF, FTC plus raltegravir regimen. Her CD4 is 477 cells viral load, is undetectable all the time. And she is in long-term withdrawal with regards to opioid dependence. It's been for 28 years. She has cured her pulmonary TB. She has spontaneous clearance of viral Hep C, markers of Hep B virus negative. Her depression is compensated. She has a family, a beloved son, home, job, income, and friends. But the war has been going on for over 4 years. Stress, air raid, sirens, explosions. Tatiana does not feel very well because she says she does everything with great effort and she doesn't feel as energetic as she used to. With regards to well-being, Tatiana's well-being in 2026, her symptoms is excessive weight and abdominal bloating, low mood, decreased libido, low energy, decreased interest. She does everything with a great effort just because she has to, and sometimes passes a small amount of urine spontaneously when sneezing, coughing, or laughing loudly. And here you can see her lab work 2026. Her weight is 87 kilos, height 174, BMI 28.7, waist circumference 90 centimeters, blood pressure 140 by 95. With regards to blood pressure, she had elevated pressure for over the last year. She does not measure it at home on a regular basis. She is not on antihypertensives. Usually her blood pressure is normal. But sometimes she had increased blood pressure, and that needs to be monitored because we do not know whether it was actual arterial hypertension or it was a symptomatic elevation of blood pressure. Next, with regards to blood, liver tests normal, glucose, fasting glucose is okay, lipids are okay, creatinine, TSH, vitamin D, ionized calcium is normal. Everything is okay. And she had densitometry performed, and the T-score is minus 1.8, which corresponds to osteopenia. On mammography, age-related involutional changes. So diagnosis and treatment plan. diagnosis: HIV infection, recurrent depressive disorder moderate, postmenopause, and history of menopausal syndromes, menopausal hormone therapy, osteopenia, overweight, and BMI is 28.7. She is getting the following regimen. She's getting ART. The regimen is TDF, FTC plus raltegravir. She is also on fluoxetine 20 milligrams in the morning, and also hormonal menopausal therapy, transdermal estradiol, and intrauterine device with levonorgestrel, vitamin D3. She needs her blood pressure to be monitored in order to see whether she really has hypertension or not. So we need the 24-hour BP monitoring and home BP diary to measure blood pressure 1 or 2 times a week. And general measures recommended, recommended diet, Mediterranean diet, aerobic exercise, walking, swimming, cycling, which she is doing. Also, she was recommended densitometry every other year. So this is monitoring and long-term follow-up. During every visit, she needs to look at her weight, BMI, waist circumference, blood pressure needs to be measured, adherence to ART needs to be reviewed, to look whether symptoms of hyperglycemia are present, and we have to do assessment of side effects annually. She needs the following things: fasting glucose, look at lipid profile, TSH, vitamin D, also CVD risk assessment should be done, and gynecological exam. Every 2 to 3 years, bone mineral density need to be checked, ART protocol needs to be assessed not to impact her metabolic profile, and complete metabolic panel needs to be done. And the purpose of monitoring: early diagnosis, timely correction, and prevention of complications. So if we talk about non-pharmacological treatment of metabolic disorders, that means diet, giving up harmful habits, physical activity, and psychosocial support. Because if it's treatment, so it's up to endocrinologists. But we, being the infectious disease specialists, we need to use non-pharmacological treatment of metabolic disorders. Thank you very much for your attention. At the end, I would like to say the following citation: do not grieve over getting old. Many have been denied this privilege, for life is given to all, but old age to the chosen few. Our goal is protect lives and health of women living with HIV. Thank you for your attention.
Дуже дякую, Інна.
Thank you very much, Inna.
За всеосяжний випадок.
Thank you for this universal case. It's really always important to know everything, to know all the history of a woman who is 57 now and who's been living with HIV for 30 years. So once again, thank you. I'm just looking at the clock, and we have 2 options. Number 1 is to ask you questions and comment, both the clinical case and also to talk about our colleagues from Europe's presentations, and option 2 to listen to the second case as well. And but in this case, we are going to be at least 15 minutes late. I don't even know what would be the best option. I don't know.
If I may
Maybe you can
suggest,
advise.
yeah, I think we should listen to Erica's presentation. And now Erica has prepared it, and then if there are any time left, then we can ask questions to both the presenters in the end. Is that okay with you, Svetlana and Sergey? But I think we should end up time. It's Friday evening, and I'm
Дуже
sure
дякую,
people have a
Інна.
lot of
Це
other
буде дуже класно, і ви
appointments.
зняли з мене тягар.
It would be wonderful. Thank you for putting the burden off me, off my shoulders. All right, colleagues.
Подивимось, послухаємо наш другий клінічний
Let
випадок,
us
давайте
hear our
подивимось
second
розлади
case
поведінки
about metabolic
катозів,
disorders in
який
a
нам
woman living
представить
with
Анжела
HIV,
Сенчук.
and it's going to be presented by Ms. Angela Senchuk.
Greetings, everyone. Thank you for inviting me to participate in WAVE webinar in Ukraine. And today I'm going to present to you a clinical case, metabolic disorders in a woman living with HIV. Her name is Vera, 50 years old, weight 63 kilos, height 171 centimeters, BMI 21.5. That was in 2026. She is married and has a 30-year-old son, and probable route of HIV infection, sexual. HIV antibodies first detected in March 2005. She was tested as a contact, and her husband tested positive for HIV antibodies in 2005 as well. She has never used psychoactive substances, does not smoke, and she is a housewife. First time she tested HIV positive for the first time in March 2005, did not seek medical care at that time, and did not receive ART until 2016. But in July 2016, she began experiencing general weakness, fatigue, weight loss of 6 kilos over 6 months, and oral candidiasis. Diagnosis: HIV infection, clinical stage 4 by WHO, esophageal candidiasis, oral candidiasis. In 2016, she was 41 years old, weight 54 kilos, height 171, BMI 18.5 kilos per square meter. CD4 9 cells, HIV viral load 63,000 RNA copies per milliliter. Antibodies to HCV negative and HPV negative, chest CT normal, and she was prescribed TDF, FTC, efavirenz, and also TMP SMX 960S prophylaxis. And since 2016, she is on ART, continuous TDF, FTC plus efavirenz. Since 17, her viral HIV RNA less than 40 copies per milliliter. In May 2023, she was switched to TAF FTC dolutegravir due to the availability of dolutegravir-based regimens. Since 16 to 24, her weight gradually increased from 54 kilos in 2016 up to 77 kilos in 2024. And over that period, she gained 23 kilos. In February 2024, her CD4 was 759 cells per microliter, her HIV viral load less than 40 copies. And in February 24, she was switched from TAF FTC dolutegravir to dolutegravir plus lamivudine. In 2024, she was 49 years old. She had menopause during that year. Her weight is 77, BMI 26.3. which is excessive weight, waist circumference 83 centimeters, blood pressure 140 by 95. And with regards to blood work, liver test elevated, ALT 81, AST 52, glucose 5.8, total cholesterol 5.9, and triglycerides very elevated 1.9. And also she was tested for viral hepatitis, no antibodies to hep C, and also her ultrasound was done, abdominal ultrasound, and there were diffuse changes like liver steatosis, FIB4 and APRI were done, and significant fibrosis was unlikely. Additionally, fibroscan was done, F0, no fibrosis, but there is moderate steatosis. In 2025, the patient modified her lifestyle. She changed her diet and she significantly reduced carbohydrate intake, and she started to follow a Mediterranean diet, and also she started to pay more attention to physical activity, and she started to make at least 10 10,000 steps per day, and also she started to exercise 3 times a week. She lost 14 kilos and her weight is 63 kilos and BMI 21.5, waist circumference 76, blood pressure 120/85. And her liver function tests normalized, and also there was a positive trend in lipid profile. The level of triglycerides decreased, and on ultrasound there were no signs of liver steatosis. And on this slide, you can see the changes of her lab test data, and we can see that in 2024, LT-AST were elevated, cholesterol, triglyceride 1.9, and as Vera modified her lifestyle, her weight decreased, the lab work improved, LT-AST became normal, triglycerides decreased significantly. So the main directions to change the lifestyle, balanced diet, it's more fresh vegetables and fruits, it's also seeds, nuts, and also added sugar was limited and trans fats were limited. Also, regular physical activity is good, aerobic exercise 3 times a day, 150 minutes per week, or strength training 2 times a week, or at least walking at least 10,000 steps a day. Diagnostic algorithm for metabolic disorders. So all women with HIV on ART, they require to have baseline assessment at entry to care. Initial screening, what we do, it's fasting glucose and the HbA1c. It's also lipid profile. We also measure blood pressure, IMT, waist circumference. We also look for anthropometric signs of lipodystrophy. And oral glucose tolerance test or fasting insulin is done, HOMA index, bone mineral densitometry is done, vitamin D, calcium is tested, hepatosis, also cardiovascular risk is assessed, it's score 2 and DAD. And if there is any changes, other specialist consultation is necessary, endocrinologist, cardiologist. So speaking about the screening for metabolic disorders, what and when should be done? Fasting glucose every 6 months, HbA1c every 3 to 6 months in patients with diabetes, mellitus type 2, like triglycerides, LDL, HDL, TSH annually, and total cholesterol as well, blood pressure, BMI, waist circumference, it's every visit, vitamin D annually, and densitometry to look at the mineral bone density every 2 to 3 years. Monitoring and long-term follow-up. Every visit, what we do every visit, it's every 3 to 6 months. We have to measure weight, BMI, waist circumference, blood pressure, look at adherence to ART, look for symptoms of hyperglycemia, and do the assessment of side effects. Annually, it's fasting glucose, HbA1c, it's complete lipid profile, TSH, vitamin D, cardiovascular risk assessment, and gynecological exam. Every 2 to 3 years, it's densitometry, it's ART protocol review to look for better metabolic profile, and complete metabolic panel. And the goal of the purpose of monitoring is early diagnosis, timely correction, and prevention of complications. Non-pharmacological treatment of metabolic disorders, usually a balanced diet. It's Mediterranean or DASH diet, and it includes limitation of saturated fats as well as omega-3 fatty acids, fish, like flaxseed oil, for example. It's limitation of simple carbohydrates and alcohol. Also, physical activity, aerobic exercise, 150 minutes per week of moderate intensity, strength training 2 to 3 times a week. It's walking, swimming, cycling. It also has positive effect on insulin resistance and lipids, and it improves mental well-being. Of course, it's very important to give up harmful habits. For example, smoking, we know it's an independent risk factor for cardiovascular diseases. Also, we have to abandon alcohol because it causes behavioral disorders, hepatotoxicity, drugs because it's reduced adherence to treatment, and psychological support of women means we have to reduce chronic stress because it decreases cortisol. It's very important to have support groups for women living with HIV, help with depression, increased adherence to ART, and healthy lifestyle. Reduction in body weight by 5 to 10% lowers the risk and improves the course of obesity-associated diseases. Like, for example, it reduces the risk of developing type 2 diabetes, it reduces mortality from CVD, improves blood lipid profile, it lowers blood pressure, it reduces symptoms of obstructive sleep apnea, and it improves health-related quality of life. And the conclusions. Metabolic disorders are clinically significant complications in women living with HIV. Women have unique hormonal factors and periods of increased risk like menopause. Screening for metabolic disorders should be regular and comprehensive. ART regimens, the best metabolic profile should be selected. Multidisciplinary approach is a key to success. So we need to work together with endocrinologists, cardiologists, gynecologists, and our goal to save lives and ensure healthy aging for women living with HIV. Thank you for your attention.
I can just say, I think I have the word now from Sergey, and I can just say that I am truly impressed with both the presentations, the mini lectures, but especially these two cases that you, Angela and Ina, have presented. I'm sorry I said Erica before. I apologize for that, but I think these two cases show a very, very comprehensive and holistic approach to women living with HIV. And I'm truly impressed with how many aspects you both presented when presenting the care you take of your patients. So thank you very much for these two presentations. I think you did wonderfully, and I don't have any questions, but I will give the word to the panel to ask whether anybody from the panel or afterwards the chat have any questions. So thank you very, very much.
So I'd like to say some words because I was really impressed with the both cases. The first case is because the real life. We see a woman with all the ages and then with the problems related to the longevity, like the menopause problems. And with all of these problems, she has a problem that is the war. So we that are not in the country, we can imagine, but we don't feel the same thing as the people that are in Ukraine living this situation. So, and can she take the medication? I think she does the best she can. It's really impressive for me. And the second case, I think, is like a dream to do this for all the patients because we need a multidisciplinary intervention. And it's very important to start the lifestyle interventions before we get older to have a better longevity. So it's all.
Так, дуже дякую.
Thank you so much. Ms. Olga, Ms. Luz, do you have any comments with regards to clinical cases?
I would just want to say that we truly face this kind of cases in the daily practice. We have seen women from a totally emaciation situation to severe obesity, and you can think of this burst, this burst of inflammation on a patient's, on an individual's health condition, and it's really important that we have to be near these patients and try to be strict to an integrated approach. This is really important. You can imagine how these people change in every aspect of their metabolic function. So it is really important to keep all this in mind and try to be next to the patient and try to make them adhere to the suggestions we make in order to prolong a better lifestyle and prolong their survival.
Oh, okay. I am agree with all of you, and they both are very challenges cases. And I have just one question to Ina, because I think that now this woman has osteopenia, um, and she's with TDF. So probably you think, or you should think of, if we need to change the treatment to this woman. But if we want to change the treatment, what should we change to? Because she's in menopause, so it would be difficult, because she can increase weight if we gave him, for example, Biktarvy. But in the other way around, I think you don't feel very comfortable with this woman having TDF. I don't know, what do you think?
Так, дякую за запитання.
Thank you very much for this question. We do think about switching, and we are going to select something that would fit her the most. We do not have Biktarvy in Ukraine, unfortunately. Right now she is on raltegravir. We might try dual regimen, but as long as she has, for example, weight gain, whether it's going to increase on dolutegravir. So here we have to think, because some of our patients on dolutegravir also have a bigger weight gain. So we really still have to think which optimal regimen to switch to. I would like to add, if I may, Ina, right, considering that both cases are from our clinic. Yes, we have discussed that. Maybe it's going to be dual therapy, considering osteopenia. Maybe we can wait a little bit and monitor, see how it's going to develop further, because no other than that disorders, dolutegravir, lamivudine. Unfortunately, we do not have a big choice. We do not have Biktarvy, Bictegravir. We don't have it. We don't have NNRTIs, non-nukes. I mean, the new ones. We don't have the new non-nukes. No nevirapine, which is good. No efavirenz. With regards to doravirine, we don't have doravirine. That's why we have quite a narrow spectrum. So maybe dual, and we are thinking about that.
I will tell you something, that I have both options, but probably I will choose also dolutegravir plus 3TC, because you avoid TAF, and I think that she has no previous resistance. I think it can be a very good option. Even though you know that it can increase a little bit with the dolutegravir, but what I wanted to say is that sometimes it's very difficult in this moment when women are in menopause, are transitioning, because you know that they are going to have probably metabolic problems, and sometimes it's difficult to choose.
Ні, тут подвійний режим це дуже хороша
I
опція.
think the dual regimen is a very good option. Thank you for providing us support with that. You know, it's good thing when you think within your own group, but then the colleagues also agree with you, then it becomes easier. Thank you very much. I do not have any more comments. What I would like to say is just express my gratitude. I've learned a lot. I've started to think about other things like calculators, for example. We tried to implement them in our clinical practice, but we will reconsider that. And statins issue is very interesting. And speaking about the second case with regards to statins, I don't know, maybe only because of the age. So multidisciplinary work is wonderful, but us ID specialists, we need to implement very simple and easy ways of monitoring and treatment. And thank you for this opportunity to discuss that and to see that our views are very close or maybe similar to your views, European views. And you are something and experience that we have to focus on and follow you. So thank you, everyone. Thank you. And thank you, Ina. Dear colleagues, thank you really very much. I think it's time to say goodbye. Who is ready to say some final words?
Well,
Thanks
if
a
I
lot
may,
for the. I'm sorry.
if I may say something on behalf of WAVE, I would really like to thank all the people who have arranged this impressive webinar. Your conditions are so challenging, and still you managed to arrange this. I would really like to thank all the speakers, both from abroad and from Ukraine. And I would really like to thank all of you who have spent 2 hours with us, getting a lot of knowledge, both from clinical trials and from real life. So thank you to all of you. Thank you so much. I'm impressed.
Дякуємо.
Bye
Thank you.
bye. Thank you.
Thank you.
Thank you. Thank you very much. Keep going with this wave in clinical case
Дякую, до
discussions. I think it's
побачення.
very important.
Bye.
Для мене теж скажу теж дякую.
To
Для мене
me,
було дуже
yeah, as
приємно
well.
проводити
It was a great,
проводити цей
great
вебінар разом з
pleasure
вами. І хочу
to have
сказати,
this
що
webinar together with you. And I
вже
would like to
восени
tell
буде
you
15-й
that
науково-практичний семінар
this
на шляху до
autumn
покращення
we are
здоров'я
going
жінок за
to have the
лікідової
15th
України.
WAVE webinar on track to improve health of women living with HIV. You are all invited. We will announce it as soon as possible. A special thanks to Nina for helping me make the correct decision. So 2 clinical cases to discuss was a correct decision. So thank you everyone very much. Thank you, colleagues, and goodbye.